Hello, I am Maria Pellisé from Head of Department of Endoscopy Department at Hospital Clinic in Barcelona, Spain. And it is my pleasure to have the opportunity to record this video explaining a research that we have recently published in gastrointestinal endoscopy. I am talking in name of all the co-authors of the paper and especially of Anna Serra-Sanferm, who is the first author of the paper. I was the last author. So this paper is titled Adenoma Detection Rate with Polyethylene Glycol Ascorbate versus Sodium Picosulfate plus Magnesium Citrate in Colorectal Cancer Screening, a parallel randomized controlled trial. What we did, our primary endpoint was to see how these two very low volume intestinal preparations were working in terms of adenoma detection rate in a fit-based population screening program. So we have these two new very low volume bowel prep, and our question was, are they the same in terms of efficiency? And we considered that for that the important endpoint was adenoma detection rate, because this is what we are targeting when we do a screening colonoscopy. What we really want is to reduce the cancer and the post-colonoscopy cancer. And we know that ADR is the best surrogate for that. So that's why we use this one as primary endpoint. As secondary endpoints, we also looked at the bowel cleansing quality using the Boston Preparation Bowel Scale, also tolerability and satisfaction, and adverse events in both groups. This is a unicenter randomized controlled trial where we included all the patients that participate in the population screening program in our country. Those are people that are 50 to 69 years old that are invited to participate, and those ones that have a positive fit will be visited by a nurse, and it's the nurse who explained them the trial, and is the nurse also who explains them the bowel prep. Then patients were randomized to receive in one group polyethylene glycol plus ascorbate bowel prep, which is 1 liter of bowel prep and then 1 additional liter of clear fluid. And the other group was randomized to receive sulfite picosulfate plus magnesium citrate. In those cases, they would receive 500 milliliters of the bowel prep and then 3 liters of clear fluids. In total, we screened 1,246 patients, and after for randomization, we randomized 1,002 patients. 501 went for the group of PEG and 501 to the group with sulfite picosulfate. We saw that both groups were quite homogeneous in terms of gender distribution, age as well, comorbidities, previous colonoscopy, and also in the risk factors for having a bad bowel prep, as well as also the Bristol stool form scale. Now I'm going to talk about the results. What we saw was that the IDR in a group with PEG was 54%, and the ADR in the group with picosulfate was 58%. There were no differences between both ADRs, so they were equivalent. When we looked at other detection rates like polyp detection rate, advanced polyp detection rate, and colorectal cancer, there were no differences between both groups, meaning that if you prepare the patients with one preparation or the other, in terms of detecting polyps and cancer, this has no impact. However, when we looked at the bowel cleansing quality, there were clear differences, and the patients prepared with PEG were much better prepared with a 97.8% of adequate bowel preps, whereas in the picosulfate group, the rate of good adequate bowel preps was above the threshold of 90%. It was 92.6%, but it was significantly inferior. The same when we looked at the transverse colon, life-sided colon, and cecal intubation, which had different rates, and what was very interesting was that in the group of picosulfate, 10 patients didn't reach the cecum because of non-good bowel preparation. On the other hand, when we looked at adverse effects, we saw that this was clearly worst for the PEG group. Patients prepared with PEG had much more nausea, vomiting, abdominal pain, abdominal bloating, dry mouth, and bad mouth taste. And that was especially more heavy in the second dose of the intake, where we have the ascorbate. The tolerability was also considered bad, and the patients were not taking the laxatives more often with the PEG group, as well as the satisfaction was much poorer. So our conclusions was that both very low volume preparations were equally effective in terms of ADR. However, bowel prep quality was significantly better with PEG-A, and patients' tolerability and satisfaction better with picosulfate, meaning that both could be used, but probably we need to choose one or the other, considering what we want to prioritize. Thank you for your attention, and thank you for the opportunity of having this paper published in gastrointestinal endoscopy.